Oh, just a second.
Myasthenia
There we go.
gravis. Ocular myasthenia gravis can present in two ways to us in ophthalmology: ptosis and diplopia. And the hallmark symptom of myasthenia gravis is variability and fatigue. So it's variable and fatigable, ptosis and or diplopia. That is the hallmark of ocular myasthenia gravis. Now, several features of the ptosis might suggest that it's myasthenia. And so when we're confronted with ptosis, we want to do a few X-ray tests. One is called the Cogan's lid twitch sign. I'll just show it to you now with my hands. So when the lid goes down in down gaze, when it comes back to primary, normally it just comes back up in the same way it went down. But in the Cogan's lid twitch sign, the acetylcholine is building up in down gaze. And so when they look up, the acetylcholine fires, but then it doesn't last and it goes back down. That twitching is called the Cogan's lid twitch sign. It's very suggestive of myasthenia gravis. We can also have enhancement of ptosis. So if one lid is down, we can lift up the ptotic lid. And because Hering's law of equal innervation to both lids is the same, when we lift up the ptotic lid, the innervational effort to the contralateral lid is decreased, and that will make enhancement of ptosis. So lifting up either lid will make the other lid go down, and we call that enhancement of ptosis. And of course, we're going to be looking for variability during the examination and fatigue. And the fatigue we can test with sustained up gaze by having the patient keep looking up, and if they fatigue, the lid will slowly fall down over time. The eye muscle almost might fall down as well. These are fatigue symptoms. So twitch, enhancement, variability, and fatigue. We also have to check the orbicularis, which, as you know, is innervated by cranial nerve 7. But we're testing the orbicularis oculi function by having them close their eyes real tight. And if we can overcome it easily with our finger, opening their eyelids, that would suggest that we have orbicularis weakness. And that is also a very helpful sign that we're dealing with ocular myasthenia gravis. The diplopia and the ophthalmoplegia of myasthenia can mimic any pattern of ophthalmoplegia. It can look like a third, it can look like a fourth, it can look like a sixth, it can look like any combination. It can look like an INO, a pseudo INO. It can look like a 1.5 syndrome. It can look like any pattern of ophthalmoplegia. However, you need to know about some of the P's that myasthenia cannot do. So Lee's P's of things that myasthenia cannot do. So what myasthenia cannot do is it can't produce any pain, because pain is a sensory finding and myasthenia is neuromuscular junction of the motor fiber. It can't cause proptosis, of course, but thyroid eye disease sometimes occurs in patients with myasthenia. So if we did have a myasthenic patient with proptosis, we'd be thinking about the concomitant autoimmune disorder, thyroid eye disease. You're not allowed to have any sensory deficit, including paresthesia or loss of perception, like loss of visual acuity or visual field. And the most important P, you're not allowed to have pupil involvement. So no P's. No Lee's P's allowed in myasthenia. You can't have pain, proptosis, paresthesia, perception loss, or pupil involvement if you have ptosis or diplopia from myasthenia gravis. Now, once you've made the clinical diagnosis of myasthenia gravis, we're going to do the antibody testing. The antibodies are anti-acetylcholine receptor antibodies. Typically, there are 3 that we can choose from: binding, blocking, and modulating. Most places use the binding as a screen. You get a few extra % out of the other 2. You might consider doing other antibodies as well as thyroid function studies. This is a practice option. We're going to do an imaging study of the chest to look for a tumor in the chest called a thymoma, and if a thymoma is present, we would take it out. And some patients with generalized myasthenia, even without a thymoma, benefit from thymectomy. In general, I don't do thymectomy for ocular myasthenics. The treatments, because there's no cure, are pyridostigmine, mestinon, and acetylcholinesterase inhibitors, and also we can use prednisone. Prednisone tends to work better for myasthenia gravis of the ocular form. I would recommend treating in conjunction with neurology, because if they have systemic or generalized disease, they might need further immunosuppression, for example, mycophenolate, or if they're in respiratory or other crisis or have severe generalized disease, they might need plasma exchange or more aggressive immunomodulatory therapies for myasthenia. So The bottom line is you should be thinking about myasthenia gravis every time in every patient with ptosis and diplopia. You're not allowed to have any Lees-P's. You're going to be looking for and asking about variability and fatigue. We're going to check the Cogan's lid twitch sign enhancement and orbicularis weakness. We're going to refer to neurology, order laboratory studies, and do a CAT scan of the chest.